Thanks, Brian. I'll take the description of being hirsute and hairy, but in reality, it is a team effort and really a dedication of all of you in the audience and the partnered sites. I wanted to, come back to the refrain that Dr. Weinberg presented, which is, and I'll just do it in a couple of minutes because it sets the stage for the next several talks. As I mentioned at the beginning, I'm a huge fan of Dr. Weinberg because, framing concepts and questions in a structured manner allows you to determine what questions to ask. But as you probably noted, he was also presenting a challenge, which is, you've heard a lot of descriptions both yesterday from the NIH and from, other parts of the world, like Mark just a second ago, about the importance of data science, data connectivity, and data interfaces. But I think it's worthwhile to take, Dr. Weinberg's caution that data on its own is not sufficient and that you have to bring these things together. And I just wanted to frame that because it's not something that we have missed. But, I think of our efforts like this, as each patient and cancer begins, there's a domino effect that's getting captured. And Dr. Weinberg tried to allude to this in creating these visuals of one gene getting mutated after the other. And part of his caution is that you actually have to understand this route of connectivity in order to interpret which domino falls first and what domino falls second. And in the absence of understanding and measuring that process, you can imagine you could be led or misled if you're only measuring, the green, dominoes, or maybe even only one domino. And so I think it's incredibly important to take to heart his caution and recognize that even and I think Mike Prados brought this up yesterday, is that the data provides a landscape against which we then ask the questions. And in the context of clinical trial development, you have to do preclinical modeling and analysis. And for us, this is the pipeline of data-driven infrastructure intersects with that discovery process, but also ensures that any basic research performed in the lab comes back and feeds into this pipeline of discoverability. And I'll spend just a couple of minutes just framing the data landscape in ways that links across that. And the key for us has been measurement. You cannot ask a question unless you measure it or measure something about it. And so for us, our foundational approach in CBTN has been to measure genomic, transcriptomic, proteomic, more recently, and upcoming metabolomic. These are all the features that essentially comprise the functionality of our efforts. And what you've already heard, like from Arash, for example, or even from Mark, is just taking that measurement required, and even from the Alex Eliminate Stand Data Lab, that measurement is not a single measurement. Unlike most measurements that are taken at the clinical interface where you're positive for something or negative for something, you're infected with COVID or you're not infected with COVID, these types of measurements require parsing in ways that you'll hear even more from in the coming sessions. But the kind of work that Arash, for example, did took transcriptomic data and parsed it out to understand the immune landscape. And you'll see that over and over in some of these components. And some of the areas that I think I'm most excited about are the parsing and integration of clinical data in ways that leverage the kind of work that Alice and Heath mentioned yesterday. And what you hopefully are beginning to see is that there's this complex network that intersects these tools and resources with these data components in ways that we are also intersecting with NIH resources and cloud-based environments. But to Dr. Weinberg's comments, this all comes back and links to the basic laboratory research that we leverage and intersects with to drive this forward, and especially the preclinical modeling as we move forward. I want to just briefly frame this combination of what Jen Mason highlighted yesterday in terms of the number of subjects and samples that the CBTN have brought forth with these data-driven initiatives that you're seeing people utilizing. So we have almost 6,000 individual samples from surgical event. And what I mean by 6,000, this is like 6,000 different surgical activities that then actually progress into more than 40,000 samples for 4,000 subjects. We've done whole genome and RNA-seq on about 1,000 of them. On top of that, we have about 300 subjects that have undergone proteomics or undergoing proteomics data generation. About 50 of them are undergoing single cell analysis. There are about 50 cell lines that are being developed or have been developed that have entered drug screens or CRISPR workflows, which you'll hear about a little bit later. The clinical data is an ongoing workflow, so it does not ever end because you're collecting clinical data and all the sites are submitting it in a continual fashion. But as was mentioned, we're beginning to ingest imaging data in ways that you'll see some cool utilities by Derek in a few minutes. And then have been really piloting efforts with clinical trial consortia and specifically PNOC on how do you not only collect real world data from hospital systems, but integrate clinical trial data in ways that Sam Vogelbaum yesterday highlighted. To make all that work, you end up having to have multiple touch points. And that includes the Kids First Data resource. Project Genie is an effort many of the CBTN sites are participating in, which brings in the molecular data created at the clinical interface. And you'll hear about this challenge and opportunity of the clinical data generation from Marilyn Lee shortly. And then you heard from Warren about the upcoming efforts in the CCDI. And one further integration that links to where we are hoping to head is a Sync for Gene initiatives by the federal government, where in this phase 4, we've volunteered to work at CBTN to test how it is that you exchange data in more real time on specific patients in order to harness all this data. And this is what I wanted to highlight is that this infrastructure, in some respects, is being built to eliminate that infrastructure. The goal is to ensure that every patient that comes through our front doors, ultimately their samples and biospecimens do not have to go through this workflow, but we can immediately interpret their disease state and biological settings through the integration of this resource. And we're just now entering that phase of integration and applicability in ways that I think are going to be hopefully transformational at the front lines. And you'll see some piloting of that from Adam Crea's presentation as we've been working on PNOC 08 shortly. So I just wanted to provide that framing as context because it's really an exciting time. And despite Brian's accolades, I'm only a small cog in an amazing machinery of willing partners. So I'll turn over to the next set of speakers, which I'm so excited to welcome to the meeting.